Excellent. So it's going to be an interactive session today. I'll be asking a couple of questions. You will answer in the chat box, and then we will kind of discuss the findings. The idea is to do it, get things right first time in radiology. I'm sure you've seen many patients where you've had, they're presenting with lumps and bumps. You're not sure what's happening and what you need to order. And I think you may find yourself in this situation. Today, we're going to try to go through it and look at how to get things right in first time from radiology, especially with patient who's got lumps. My name is Mohammed El Sayed. I'm a radiology consultant. I'm the co-clinical lead for radiology at BHRUT. I would love to get a feedback from you guys who attended today to help me to improve on my teaching and the context and the content we're providing for you. So if you could spare a couple of minutes to give a feedback, this is the iwantgreatcare.org website. Search for my name, of course, writing the correct spelling, because I've had some people writing different spelling and giving review for different person. So I appreciate if you get the spelling right and give a feedback. I really appreciate that. So this would be helpful. If you haven't got an account on iOne Great Care, it doesn't matter. You just go onto the website and do the feedback. I would encourage everyone to register for their own feedback from patients. This helps me a lot in appraisal and also to tailor my service to my patients. Now, if you are one of these, doctors or, clinician who's kind of not sure about which test to use, and sometimes you may be thinking, am I giving a lot of radiation by asking for CT scans or X-ray, or you may really worried about cancer and you're not choosing the right test. Today, we're going to go through this. We will cover you. Will be a lot of opportunity for us to share our knowledge and experience and to go through different examples today. So what we will learn today is what is the right scan for a lump and why. And how we're going to do it today is going to be interactive session. I'll be asking questions, giving you scenarios. You'll be giving me your thoughts. And again, this is a very friendly platform to share our ideas. So please come forward and give your answers, because this will help me as well to learn how you think and how you process the information and how it could help you in radiology to deliver best patient care. We're not going to be discussing any treatment options today, and I'm not going to show you any fancy X-rays or complex imaging. It's pure friendly chat, a discussion about what to do next if you get a patient who's got a lump. Now, I chose this title, Lumps and Bumps from Head to Toe, because you see this every day, day in, day out, and it's a common problem. And patients are always anxious about lumps because...
not too bad yourself.
If I can ask everyone to mute their mic, please. I'll be Perfect, thank you. So lumps and bumps comes every day. We are always worried if we're going to miss a cancer. The patient's already coming very worried and very charged by the emotions that it may be a cancer because of family friend who's died from cancer. So we want to make this as safe and possible to participate. So please put your opinion forward, share your ideas, because I will learn from it and you will learn from each other by sharing your ideas. There's no reservation asking any question at any time. We've got 15 minutes at the end, so you can ask questions. So we'll keep going until you are happy with this. Just quick review on the imaging we provide in radiology. So you find X-ray on the top right, which is basic X-ray, low radiation dose. We do like 200,000 examinations per year. So this tells you how much this department is busy. Ultrasound, we also have the biggest number of ultrasound in the whole network. We do about 250,000 ultrasounds per year as well. It is safe, it is friendly. I really like this modality because it gives you quick answers in the right hands. And it also helps to relieve patient anxiety, having someone to talk to who could actually give them some advice. The top left is an MRI scanner. It is very deep, as you see there. It kind of, when the patient goes in, it engulfs the patient inside. So some patients are claustrophobic and they really can't tolerate the examination, but it's a very useful tool because it helps us to identify complex soft tissues, complex pathology within the small bowel, large bowel, and the brain. CT scan is our workhorse in BHRUT and is the workhorse for every hospital. And it helps us identify, causes of weight loss, any pain, any lumps, but we don't use it that often for lumps. But these are the main modalities we have in radiology to investigate lumps. Now, this is the first child with a scenario, 4 years old with a firm, hard scalp lump. The options are, what would you ask for? Number one, X-ray, CT, ultrasound, definitely MRI, or ultrasound. So number 3 is ultrasound cannot be used as it's on top of the skull bone. And number 5 is an ultrasound. If I can have in the chat box a couple of responses would be great, just to see how people are thinking. So child lump in the scalp. Okay, perfect. I can see 5s and 1s coming. Perfect. And now I can see 3. I just need a couple of more. 5. So I have to say that the winning is 5, but I can see a couple of 1s. So I would go for ultrasound. I think this is the correct answer. X-ray is not a bad idea, but I think for a child, we try to stay away from X-ray, which is an ionizing radiation, as possible. And I know that some people can be put off that is a lump, can feel hard on the skull, then it must be bony. I want to exclude bony lesions. And then they ask for X-ray. It's not a bad thought, but I think for children, we prefer to go for ultrasound. So from now on, if you get a 4-year child with a firm or hard scalp lump, go for ultrasound first. If you find something with ultrasound and we find an answer, end of the story. If we didn't find, then we may go for X-ray or CT or MRI. But I totally support the number 5 as an option. Number 3, ultrasound cannot be used as it's on top of the skull bone. And I think I've answered why this is something that we should be aware of, that ultrasound can still look at scalp lesions even if it's on top of the bone. Perfect. So do not ask for X-ray of the skull as a first investigation, please, especially for children, even in adults. The new GIRFT guidelines, which is Get It Right First Time in Radiology, suggested that we should not be requesting X-ray of the skull at all, no matter what the reason, even if it's a trauma. So this is a take-home number 1 point. So please don't forget this. No skull X-rays for lumps. Start with ultrasound first. If you think it's a big lump and you're worried, then CT or MRI. 8-year-old child with a face lump, parotid or submandibular region. Again, you've got a couple of options there. I made it 4. Says X-ray is a low radiation and will tell me if there's any calcification or stone. Maybe it's a good thought. CT will show the lump better. Yes. Ultrasound, perfect. Definitely MRI. Okay, I can see. Okay, so there's a challenge between 3 and 4, but I think 3 is winning. Perfect. I'm very happy with this. I'm really satisfied. Yeah, you've all chosen the correct answer. I think number 4 is not a bad answer, but I think don't forget, MRI is a very scary place. It's a very big and long tunnel. When you go in, it just swallows you in. And for an 8-year-old kid, it can be intimidating, because it can be actually intimidating for adults. So I really like this. Everyone got to try it here. MRI is not a bad idea at all. We use it sometimes, but if it's needed and we can't find the answer with MRI. With children, always make sure that you choose ultrasound. So this is the MRI scanner. You can see it's very big, and the patient will go in and he will swallow the whole patient. And actually, when you go in, it feels like this. It feels like you're going into a box which is scary. It is dark. It is dull. Some people feel really worried when they are in the MRI scanner. And for your information, we give every patient like a panic button, so they press it when they feel they can't stay in. And we have this on a daily basis. Patient cannot continue the examination because they feel they're actually inside the box like this. This is, of course, the scanning box in the airports. Now, another one. There will be recurrent themes, and the same question may be answered many times, but I think it's good to catch it from different angles so that we appreciate everyone how they can talk it. I've got a question here in the chat box that GPs cannot request MRI in a child. Well, I don't know what maybe this is your experience, but I think many GPs are requesting MRI scans for children, and we do accept them. Now, for this one, child with a neck lump, yeah, perfect. Ultrasound is the best modality. I totally agree with people who chose this. I think you all got it right. Perfect. I think this is good. Shows good learning curve. Perfect. Why is 2-week wait? Correct. Yes. Yeah. So yeah, the good question. Why did I put 2-week wait? Because I'm sure you've seen this. Every mom or dad will come with a child with a lump. They always think the worst. So they will come worried about cancer, and then there'll be pressure on you to ask for the most complex scan and refer to 2-week wait pathway. But I think it's our duty to reassure that we will choose the right test from the first time, which is ultrasound. This will give us an idea what's happening. There's quick turnaround time. There's no big waiting list so far, although it may change. And it will then result in a finding which we then may need to refer if needed, but no need to refer to for 2-week wait referral if there's a lump, even if there's any pressure. And this is my explanation for the question. I hope this is satisfactory. Number 3, adult with face submandibular lump. So this is an adult this time. Refer to specialist, CT, ultrasound plus or minus FNA, definitely MR as complex part of the body. Scan is not needed as most likely to be something. Perfect. I am very happy with this again. Very good. Perfect. Excellent. I think you all got this right. There's no need to stand this further. I think in previous presentations, some people chose number 5. No need because it's most likely to be a cyst or a benign lesion. I think in this time of high litigation for doctors, I don't think there's a need to assume anything. I think it's better to identify what it is and be 100% sure about it, and then you can rest it and reassure patients again. Perfect. Another scenario there. So again, I'm repeating things, but I think it's good to, make sure that we choose it the right thing. Yeah, ultrasound, perfect. Yeah, so now I can see most 5, but there's a couple of 3s. And again, I've answered this question on the same slide, first slide. So even if it's on top of the skull, you still can use an ultrasound scan. It doesn't have to be a bony lesion. So if it is mobile, if it is bulging, if you can feel it, if it's firm, even if it feels hard on top of the skull, I think ultrasound for children is the best modality. So let's fine tune this now and make sure that we request ultrasound for any lump in the face or the skull, unless it's really bulging and big and you would think it's, cancer or developmental abnormality. Right, I hope you can see this picture here. Now, this is an adult now with a fairly large lump, maybe 4 centimeter. What would you do? X-ray, CT, definitely MRI, ultrasound, refer to specialist. If I can have responses, perfect. Perfect. I'm really happy you're getting it, all of you now getting it right first time from, yeah, perfect. So some would say I would refer to a specialist. I had this in previous presentations. Some say I had many responses to refer to specialists. I'm sure that you're doing much better than the other group by now because they worried it could be cancer. But again, if you have a history which is suggestive of a cancer, then please do not delay. But if it's been there for a couple of years, getting slightly bigger over the time, I think it's safe to go for ultrasound first before you refer to a specialist and take time of the patient. So by now we need to establish this. Yes, ultrasound is for any neck, face, or scalp lump as the first step of investigation, provided there are no red flags. Now, an adult with shoulder lump. Any age? Could be from, any age from 20 or 18 till 90, 100. Let's check some responses. We've got number 3 now. Perfect. So we've got 3 and 4. Okay, good. Perfect. I like this. Yeah, please keep going. Keep going. I think you're doing excellent job, guys. Yeah, your participation is very high. The highest group I've actually worked with so far, although you're big in number, which is great. Excellent. So I can see 4 is dominating, which is ultrasound is safe and adequate. You can see the lump there. Let me just look at it again and see whether. Then I'll remove this box. Yeah. Okay, perfect. So now the difference between this lump and other lump is got something different about it. It's got redness, it's got central focus of ulceration. So it's not a completely bad idea to start with ultrasound, but I think it is safer for this particular lesion. It doesn't look typically like a lipoma. It doesn't look like anything simple like sebaceous cyst. So I would actually refer this to a specialist, but I don't think ultrasound first to start with as a wrong idea, but you may get an unsatisfactory answer, and then you have to refer to specialists. So this action of sending it for ultrasound first may cause a bit of delay. I've attached the image with an arrow just to give you a bit of differentiation between this image and the image we had there. This is different completely. So just make sure if you see something like this, it looks a bit complex, bit odd, better refer to a specialist. Ultrasound doesn't, doesn't stop you from ultrasound, but refer to specialist at the same time. Right, another lump there. What would we do? Yeah, excellent. Again, learning curve is very, very high in this group. I'm very pleased about this. Excellent. You all got it right. Yeah, refer to a specialist. It doesn't look like something we would do ultrasound for. And actually, if you send it to us, we will do ultrasound. It will be non-specific reports. But a specialist may look at this and say, oh, actually, it looks worrying or cancer, or just leave it alone. Perfect. 5-year-old girl with asymmetrical breasts. Any thoughts on this? Good, perfect. I can see less people coming for this answer. Okay, perfect, perfect, perfect. Good. So I have to tell you guys that you have fallen into the trap. Sorry about this, but this is a fact now. So 5-year-old with an asymmetrical breast, the first modality will be ultrasound. So I would agree with the group who went for ultrasound. MRI is too intimidating. The child is very small. It's going to be non-specific because you see in the MRI machine is huge. The child will be there, will be moving, so we wouldn't get an answer. And actually, it's very common to get asymmetrical lumps, asymmetrical breasts in girls, and we scan them, and it usually shows a bit of asymmetrical early gland formation. So no need for MRI. So yeah, I can see someone saying rejected by radiology. We are not allowed breast ultrasound scans. Okay, are you talking about BHRUT, Nadia? Yes. Okay, we will. Okay, so request ultrasound breast. Okay, perfect. So there's a way around this. I'm not saying a way as like scheme with the system. It's a chest wall. It's asymmetrical breast lump. If you can't refer directly, it's usually benign. It's usually glands. So there's no need to refer to something, anyone complex, unless you are worried about infection or a mass lesion. If you're worried about infection or mass lesion, so don't refer for ultrasound. But for a 5-year-old girl or 8 years old or 11-year-old girl with an asymmetrical breast, I think it's safe to send for ultrasound. I will discuss this with our team at BHIUT and see why exactly they are refusing this. There may be a specific pathway. And I know when you say a breast, it needs to be scanned under breast ultrasound team. But I think this is something that a pediatric radiologist who doesn't do breast imaging can scan. And we do this all the time. So I do some of my practice pediatric and I scan them in and out. And I understand your anxiety because in the private sector, they have the same rules. Breast, no one can do it except breast team. But this actually is not a breast, it's a pediatric. So it's a chest wall. So what we said here, if you refer as asymmetrical chest wall, and then we know it's a breast, we scan it and then we give the imaging. But I will find more from you and maybe update Jyoti on this. No, you can do breast ultrasound at KGH and Queens. Yeah, yeah. So let's not confuse things. If you want a breast ultrasound, it has to go through breast clinic, but it's for adults. But for kids, it's different. It's pediatric service. And there's a question from Christian. If you suspect infection or mass lesion, CT or MRI, no, I would still go for ultrasound first because 99.9% of the time, it's just asymmetrical breast and there's no mass lesions. So if you found a mass, we will still do ultrasound, confirm it's a mass, and then we send it to the appropriate specialist for breast masses in kids. I hope this is helpful. Please ask any questions if you have any. 12-year-old boy with asymmetrical breasts. Okay, so this is 12-year-old boy this time. What are we going to ask for? Of course, you can reassure them and say it's whatever you think it is. Okay. 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 I'm glad that only one person fell into the trap, but most of you got it absolutely perfect. So yes, ultrasound is the first modality. You could, yeah, number 4 is not a bad choice, I have to say. So no need for a scan is one of those things. But again, they always come, the people now, they come with equipped with Google. So they go to Dr. Google and they research what is this breast lump, and Google will never tell them it's gynecomastia or something to reassure them, always make them get worried. So they come to you worried and you say, oh, it's fine, and then no one will be actually happy. So again, why would you assume? Let's just get it done by a scan, confirm it's a scan, and let it go from there. With this age, I would say 12 years old boy, if it's really asymmetrical and looks abnormal, I wouldn't think that sending it to a breast clinic is a bad idea. But I think we do this all the time as well as pediatric radiologists, and we do them with ultrasound, and we reassure the patient and the family, and then it's all done. You will have different practices everywhere. So I know you all understand that if you go to King George, is different than if you go to Whipps Cross, like Queens. Everyone has their own different pathways and ways of doing things. People are set in their own ways sometimes. But I think it's a good opportunity to discuss this and then understand the limitation of the system and understand that there's limitation in how people accept referrals. But now you know the best thing is to do ultrasound. So either do it through a clinic or do it through direct referral. Whatever your system allows you to do, you're doing the right thing for the patient. Another lump here, 30 years old patient with a visible and palpable chest wall lump in the back, of course, but it can be in the front. It's away from the breast. It's not a breast lump. I'm specific about chest wall lump, and it's less than 5 centimeters. What would you do? Okay, I can see lots of ultrasound. Yeah, perfect. I totally agree. I haven't seen anyone gone for MRI. Oh, someone has gone. No need for a scan if not painful and mobile. I wouldn't agree 100% on this because again, we don't know what this lump is, and I haven't given you any information about how long it's been there for. If it's been there for like 5, 6 years, yeah, you could say no need for a scan if not painful and not and mobile. Yeah, I would agree. But with this limited information, I would say do a scan and ultrasound will be very adequate for this. And of course, at every stage of these questions, if there are any other red flags, then you have to raise the 2-week wait pathway or send to a specialist. We're talking about the standard, which is like 85% of patients who comes, they come with benign lumps. They just want to be reassured. They want to know what it is, and then you can forget about it. Perfect. I had some, the reason I put this slide is someone on a previous course, they said a lateral chest x-ray to look for calcification. So please do not ask for lateral x-ray at all because it's not indicated. Because I know you could see the soft tissue if it was in the front here or the back there. But here you see some of it is already cut. You can see lump there. Yeah, if it was calcification, yes, you can see calcification, but what value will this add? And it's a large radiation dose. This is a very big radiation dose. We don't even now request lateral chest x-ray for any unusual finding on an AP or PA chest radiograph. So please, lesson number 2, do not ask for lateral chest x-ray. If you're gonna go for lateral chest x-ray because you're worried about a finding, I would rather you go for a low dose CT scan. It is close to lateral radiograph, but give us much more information. So I would think if you take off skull X-rays and take off lateral X-rays from your, life, I think everyone will be happy. We will be happy as well. So I just thought I would just have this calm down to tell you our life in radiology. So we have in radiology a very, very busy life. The demand on radiology now is unprecedented. It's like yeah, like a life of hell, to be honest. But it's good to be busy, but it's too much. So we work all the time. So I go in the morning, I go 7 o'clock in the morning. I'll find like a couple of radiographers waiting to ask for a couple of scans. And then we authorize that. And then we start reporting, get interrupted, and then have lunch or a break, and then still reporting all day and all night. Even when we go home now, because you can access your work email on mobile. You just look and then you find someone who wants a second opinion and you go there. So we are working all the time. So this makes us a bit, sometimes tired, and sometimes you may get different opinion from different radiologists, again, depending on their training and where they have had their core training. And because it's a diverse community, and we get radiologists from the UK, we get them from Europe, we get them from Asia, and you get people that had different training backgrounds, and then you may get different opinions. So there's no such a wrong or right opinion, but make sure that you, if you have a chat with a radiologist, just understand that there may be different variation of how we look at things depending on experience. Now let's go back to scenarios. Thanks for the sympathy, Kirsty. That's very nice of you. 15 years old child with palpable chest wall lump, front or back. The 15 years old. The one we talked about was adults. 2, perfect. I can see everyone now. Perfect, perfect. You're getting it all right. Number 2, but we don't need to sit on this more. Perfect. Now another big lump here, base of the neck with cough and recent weight loss. CT will show us the lump better. Ultrasound, MRI is the best. Soft tissue masses. No need for a scan if not painful and mobile. It's a tricky one. Yeah, someone is asking, Kirsty, is 2 is enough? 2-week wait, yeah. So well done, good, yeah, yeah. I would say yes. 2 is a good to start with, but I think having the weight loss and cough will make us think something more suspicious. So I would say start with an ultrasound first, but refer on a 2-week wait, which I didn't put there because I wanted to see if anyone's going to bring this to discussion, and someone has, which I'm really pleased about. MRI for soft tissue mass, yeah, it's not a bad idea, but I think we just have to establish, because although this linking things together, we don't know whether the weight loss was intentional or not, which may be intentional. We don't know whether the cough was long-standing for 20 years, if the patient was COPD. I'm looking at the comments, so not CT, ultrasound. Yeah, someone say, so not CT, ultrasound and referred to 2. I would say, yeah, ultrasound referred to 2-week wait, because we sometimes get a lot of referral for CT scan, and we do CT neck, chest, abdomen, and pelvis with contrast, and it's nothing. It's just nothing at all. It's just a benign lump, lipoma, or something different, or a cyst. Someone asking, what does WW stand for? So 2-week wait is, sorry, I wrote it wrongly. It's 2-week wait, referral, like cancer pathway. Sorry, I didn't write it. Right, let's go for this one. So now 49 years old patient with a visible and palpable shoulder lump more than 5 centimeter. And if you remember, there was another slide less than 5 centimeter. And now this is a shoulder lump, which looks, when you look at it, more than 5 centimeter. Okay. So I have to tell you guys that I'm pleased that you all fell in the trap again, which is actually good, because this is the time to discuss this. When it's more than 5 centimeter, although ultrasound scan can be a very good modality to tell us what is, when it's more than 5 centimeter, for example, and we think it's a lipoma, I'm sure you all think this is a lipoma, and this is a lipoma. But when it's more than 5 centimeter, ultrasound cannot exclude atypical areas within this big lump. If the lump was less than 5 centimeter, then ultrasound will be able to capture it and look and identify about abnormal areas and reassure the patient. But if there is if it's more than 5 centimeter, it's going to be big for the probe, big for the ultrasound assessment. It's just above the ultrasound ability to define it. I'm not saying that ultrasound will not be able to say it's lipoma. I'm sure if I scan this, I'm going to say it's lipoma, but I'm going to recommend an MRI scan to further assess. So now it's up to you. You've got the information now. I'm not going to tell you just do this, because there is no right or wrong on this answer. I think you could go for ultrasound and then the person will scan, will say, actually, I'm very confident it's a lipoma, but you may find someone else will say, no, do it an MRI. And this depends on the location. If this was an intramuscular lipoma, we definitely have to do an MRI. And this can be identified with ultrasound. So the value of ultrasound here is to say, is it subcutaneous proper, or is it intramuscular and just bulging out to the subcutaneous tissue? Yes, and there's no right or wrong answer here, but I think you all did well choosing ultrasound, and even the second choice you all chose was MRI. So no one has said number 4 or number 1, which is I'm pleased about, to be honest. Another lump, less than 5 centimeter. Can you guess? Yeah, 2, perfect, perfect. Yeah, I think you all got this one 100% right. Less than 5 centimeter, do ultrasound first, full stop, perfect. Unless, of course, you've got red flag items. 15 years old child with palpable shoulder lump. Again, we should go quickly on this. Perfect. I'm not going to stop too much. Yeah, you're all getting it perfectly right. Excellent. Amazing learning curve. Perfect. Now, another one, any lump anywhere in the body that has increased in size. Yeah, yeah. Depends on the size. Very good. Yeah. Christos, very good point. Yeah. Depends on the size. So yeah, again, I've got 2 and 3, and I think both are correct answers. It depends on the size, of course. It depends if there are any other associated red flags or anything to make us worry about this lump. And I think both are correct. If it's increasing and it's still small, I think ultrasound should be go for it. But if it's really got big, above 5 centimeter, we go to the same principle. Above 5, better ask for an MRI scan if you're really worried. Perfect. I'm really happy with this. So it's not 117, it's number 17. 49 years old patient with visible and palpable abdominal and pelvic groin lumps. Okay, I can see 2. Yeah. So if it's visible, and I've mentioned visible here, and I'm sure that that's why you chose it, ultrasound will be the first one. If it's visible, definitely ultrasound to start with, because we could assess it. Again, depends on the size. If it's small, less than 5 centimeter, you're more confident to ask for ultrasound. If it's bigger, then you still can ask for ultrasound, but you have it in the back of your mind that, oh, I may need to ask for MRI, or I'm expecting someone to ask for MRI. Just be prepared. Because if you ask for MRI straight away, I think it may be pushed back and say, do ultrasound, because it could be just a cyst. Again, it depends on the history. If it is sounds malignant, then referral is the best way forward. Perfect. 62 years patient with abdominal lump who recently has had a DVT with no known risk factors. This is a tricky one, so have a think about it again. Okay, I've got a nice battle here between 1 and 2, and then 5. 5 is kind of winning now. Need a couple of more just to see which one team is winning. Okay, between 1 and 5. Yeah, I'm very pleased about this as well. So I would ask for a CT scan and send for 2-week wait referral. You could say, why don't I just send for 2 weeks and they will deal with it? It's because sometimes it can take time for this to happen, and the 2-week wait referral office are inundated with scans, with requests. But maybe if you request a CT scan and 2-week wait referral, and just say that you've requested a CT scan, I think this will make things go quicker as well. But yeah, my best option is 2-week wait referral, because they can deal with it, escalate the scan, have the scan time efficient, get it reported. And this is worrying, is you've got a lump in the abdomen and there's a DVT. So there must be malignancy or some pressure on the leg causing this DVT. 40 years old patient with palpable abdominal or pelvic lump, not visible, so you can't see it. Perfect. I'm getting 3 and 2 ultrasound. Okay. I think, okay, so it's a tricky one again. So it's not a visible lump. You can't see it on the abdomen. Maybe on palpation, you could feel something. And I think this would be worrying. And I think, although ultrasound is a good option, you can start with, provided your suspicion level is very low. If you have high suspicion, then CT scan would be the way forward with contrast. And we talk in a different session about when to ask for CT scan with contrast and what's the risks of contrast administration, what discussion you should have. So yeah, someone asked about number one. Yeah, I think CT will be the best option that I would go for, because it's you can't see it. It's patient is kind of still young, but you don't know what's going to be happening there. So if it's not palpable, sorry, if it's palpable but not visible lump, do a CT scan. Perfect. And also putting this because there was another group who mentioned X-ray of the abdomen. Again, please do not ask for X-rays at all to interpret anything like, yeah. So there's, yeah, I'll continue to come back to you. So don't ask please for any X-rays of the abdomen because the diagnostic value is very minimal and they're not really helpful at all, and it's a big radiation dose. Again, we would rather do a CT KUB or do an ultrasound scan, give you better information. Again, GERFT, get it right first time. I'm sure you all heard about it. Has suggested don't ask for plain X-rays for acute abdomen or to characterize a mass lesion, unless you're really thinking it's specific mass lesion like a dermoid, you want to find fat or anything like this. But again, we use MRI, we don't use X-ray for that. So again, if you're going to take skull X-rays, lateral chest X-ray, abdominal X-ray from your life, we all will be happy. Perfect. 32-year female with incidental echogenic liver lump on ultrasound. So there's a typing error there. So 30 years old, so young female, had an ultrasound for abdominal pain. And so just before we go to this, there was a question, why not MRI in the previous case? Yeah, I don't think it's a bad idea, but you don't know whether it's gynae or MRI or not. We said abdominal pelvic pain, so it could be a mass in the liver or anything like this. That's why I didn't do gynae. So on this number 20, 33-year-old, MRI with contrast, characterize the lesion. Okay. Number 1, 2, request referral. This could be malignant. Okay. So most of the answers was 1 and 3, and 1 is winning by far. Okay, so again, this is a very good slide because we can have a good discussion about this. So NICE guidelines mention that if you have a young female, 30 years old is young, with an incidental echogenic liver lesion on ultrasound, it's most likely to be benign hemangioma or focal nodular hyperplasia. We call it FNH. So for that, we don't need an MRI unless we can't really characterize it with ultrasound. And if you look, number 4 is microbubble contrast ultrasound. No one has chosen this, which means that maybe some are unaware of it. So microbubble is the NICE guidelines test of choice to confirm if this is a hemangioma. It's a quick test. We inject a very safe contrast into the antecubital fossa, and then we scan the liver. It's live scanning. It shows you how beautiful it is FNH or hemangioma. End of the story. No MRI, no intimidating machine, no nephrotoxic contrast, and no bad experience with claustrophobia. So if young patients, yeah, I think someone asked what, can you ask for a 4? Yeah, of course you can ask for 4. It's the best thing to go for. We get a lot, I have to say this, guys, it's a platform, we have to confess. We get a lot of requests from 2-week wait referral asking for an MRI or CT liver for these lesions. And if it doesn't go under vetting, because some radiographers will vet, so it sounds, sensible. There's echogenic mass happen in the community, the ultrasound, they're not sure about it. And then it happens that they send it for us for MRI or CT liver, big radiation dose for a young female, and actually it is just a hemangioma, which microbubble contrast ultrasound, very safe, very quick, and very accurate, can help. So we can have another lecture if you all like this about microbubble contrast ultrasound, just to inform you more about it and how it can help you in identifying these things. And the experience is quite better because they have a chat with the radiologist who's doing it. They can know what it is exactly at the same time, and it eases the pressure and the fear. You can request it as a GP, of course. You don't need this is what I'm saying is the best test. It is safe, it doesn't cause nephrotoxicity or liver toxicity. You don't need any test before. You just send it to us, we will do all the rest. Shouldn't the sonologist recommend this? If it comes from BHRUT, I think most of them or some of them will request it. If it comes from the community, the chances that the chances are high or that they don't know about this modality. So that's why they don't request it. They always say further imaging, and I've seen many of the community reports, further imaging, MRI, can't guarantee what it is. It makes you worry, and you haven't seen the images, so no one can blame you. But now you know better. You know that, any echogenic incidental. So it's incidental. It's not a patient who's known to have cancer, not a patient known to have weight loss or anything like this. Incidental, went for pain, found this lesion, and now we got distracted by looking at this lesion and forgot about the pain, as we always do. And then the patient will be anxious till MRI scan, waiting time is longer, and all the story. We want to help the patient, help you to get this right. So community sonographers will not request it because they don't know about it. And now you know about it. So I'm sure you could use this to your advantage now. I have had young female patient with echogenic lesion in the liver. Advices interval imaging. What is this piece? Okay, so interval imaging is when the person who saw it has got extensive experience in ultrasound, and they think actually, okay, if it's echogenic, it's young female. I'm 99%. It's hemangioma. We don't want this patient to have ultrasound. We don't want this patient to have MRI or contrast or CT. Let's just give this patient another interval scan. I think it's adequate thing. Now, we've reached the time where the questions, there are two options from now. We could keep going now, you're asking questions as we go, or we could just stop and have questions and answers. What would you like guys to do? The last question, interval scan, another ultrasound, yes. If you type in the chat box number 1, yeah, if you want questions or you write questions, or number 2 if you want us to go, and someone saying carry on, we'll see how many. Why don't you write 1 and 2 so we can calculate the numbers? 1 if you want me to continue the presentation, and number 2 if you want to ask questions. So because I can see more ones, and 1, 2, Christos, nones, number 2. Okay, so to be fair, let's continue for another maybe 7 minutes, and then we'll leave questions so that everyone is happy with the day. Okay, perfect. 41 female with bloating and possible pelvic lump. So does anyone has got any? So we've got 1 and 2, CT, ultrasound. 2, yeah. Okay, good. I think people who went for ultrasound, I don't think it's a bad idea to start with. The bloating always makes us think of cancer, which I think we have to keep it like this, because I see lots of patients coming with this symptom, just bloating and a bit of fullness, and then we find ovarian cancer. We can detect it with ultrasound, but the best is MRI. But I would always say start with ultrasound first. If you're really confident that the patient having weight loss looks really bad, then this needs a 2-week weight referral, and then either we'll do a staging CT and an MRI to characterize the liver lesion, the ovarian lesion. But please go ahead and ask for ultrasound first, because it's easier, quicker, easy to fit, doesn't cause any delays. Perfect. 69 patient with a pulsatile abdominal or pelvic lump. CT angio, yeah. Perfect. CT angio 1 or 2, yeah, I like this 1 or 2, yeah. 2, 2. Perfect. So I think, yeah, whoever replied, I think you all got it right. Yeah, there's no right or wrong answer. 69, so there's a higher chance of this person having aortic aneurysm, and CT angio is the best modality. But I think ultrasound as well is quicker and easy and will get us the answers straight away. And if then it is really more than 5 centimeters, we do a CT angio and keep this patient under surveillance under vascular team. So start with ultrasound, because the reason I'm getting this again is we get so many referral from GPs, CT angio aorta for pulsating mass, and actually it is normal. And with CT angio, we give a high radiation dose and a very high contrast dose. So if we did an ultrasound, we may find that this pulsating lesion is just, transmitted pulsation from the aorta to the, soft tissue and then to the abdominal wall, which will look to you like it's a pulsating mass. And I've written something here at the bottom: be aware of slim patients can cause pseudo pulsating mass. You put your hand, you see something pulsating, you get worried, and then you ask for CT angio, and then there's nothing there at all. I mean, there's nothing wrong with this. You have to sometimes use a clinical judgment. And if you're worried, especially in this age, no one will blame you. What I'm saying is there's another option to think of, which is ultrasound, quicker. It can be done even the community to find what it is. And if you're not happy or satisfactory, then you do the CT angio. 59 years old with an incidental suspected cyst lump on ultrasound. Okay, let's skip this one because it needs more discussion. Here we go. That's a nice one. Lump on the dorsum of the hand or wrist at any age. We need this 100%. Perfect. I can see this happening now. Two. Perfect. Excellent. Yes, correct. Most likely to be a ganglion. Could be, if the patient is younger, could be AVM and angiovenous malformation. But yeah, ultrasound is the best thing. Well done, everyone. MRI is not a bad idea. If someone said MRI, I wouldn't be upset or say, I think it's adequate, but I think ultrasound, it can help, because sometimes you can even aspirate it at the same time. So you may be helping the patient to say, ultrasound plus minus aspiration. We do it at the same time, book him for the right slot or book her for the right slot, and then scan, aspirate, end of the story, it's finished. Of course, you need to have a discussion with the patient about aspiration and well, how it's done. Again, leg lump, heel lump, again. So I can see 2 and 3. Again, never knew we could request aspiration. Good to know. Okay. Perfect. Yeah, I think the answers are very adequate, very, very good, actually. Ultrasound and MRI. Ultrasound is dominating. Yeah, start with ultrasound first. The only reason I got this slide is the foot and ankle is one of the most known areas of synovial cell sarcoma. It's not a very common tumor, but it is very common in that region. So whenever you get anything in the foot or ankle, please make sure you scan it quickly. I think ultrasound will be the best thing to start with. If we found it suspicious, we will let you know, and then we'll ask for further imaging and referral. If we found it like a gangrene or lipoma, we will also let you know. So just want to make sure that you, in foot and ankle, if you get a lump, think of synovial cell sarcoma. Good. So we're nearly finished now. So take home points. Step 1, think like a radiologist. See what scan you want to request and how you want to ask the radiologist, and use a guideline of GIRFT. There's a big document about GIRFT in radiology. Please, if you have time, have a look at it. If you're not having a time, I've given you most of it today. Don't use X-ray for the skull. Don't use lateral chest radiograph, and don't use abdominal X-ray to find anything. With children, ultrasound is the safest. Any lump anywhere in the body, just use ultrasound. You'll be safe, and you'll be requesting the right test. I hope that after this journey, nearly an hour now, that you have developed your art and skill of choosing the correct investigation in radiology without worrying about, worrying anything or contrast-induced nephropathy or delaying patient management. Please don't forget to go on iwantgreatcare.org and leave a feedback so that I can learn and improve on my presentation. Now I've got 7 minutes for questions. So please feel free to ask any questions you want. So now at the end, and I have to say I'm impressed with myself multitasking between chats and keeping the time and looking at you guys. So I hope you all notice this. So any questions? Can I just confirm if painful and likely to be gangrene? Yes, if you think it's gangrene, you can send for scan plus or minus aspiration. Yes. Provided you have the discussion with the patient about aspiration, what's going to happen there. because we inject steroids. So you may need to discuss the patient injecting steroid at the same time, or specifically say do not inject steroid. Could radiologists be more specific with us? Scanned number of us sometimes. Yeah, well, it's a fair point, Nadia. You need more specificity, but as I mentioned, the radiologist time is, so if you come to me in the morning, ask me a question, I will be very full of energy. I'll give you all the answers you want, and I'll show you the scans. If you come at the end of the day, after you've had a very busy day, the energy level will goes down. But, and also I mentioned that some patients, some radiologists come from different backgrounds. So they don't have, not the ability, they don't have the structure of working with GPs because they don't have GPs where they work before. So, but something I would take it from here and I will try to disseminate within the team and ask them to be specific on what next step. Although we've been trying this for many times, but I will keep trying. No, thanks for pointing this, Nadia. Thank you guys for the nice words. It's my pleasure to be here with you. I've learned a lot from you and how you think as well. Coming back for interval imaging, how long are the intervals? That's very good. The safest period is 3 months. So don't make it 6 months, don't make it 12. The safest initial interval is 3 months, unless the radiologist specify how long it is, 3 months. For chest x-rays, is 6 to 8 weeks, as we all know. But for any lumps anywhere, anything that you're not sure about, keep it under review for 3 months. Someone asking more on feet. Jane asking more on feet next time. Yeah, we can address this. Yeah. Thank you very much. Why do radiologists sometimes change ultrasound hip request? Ah, that's a very, very good question, Mariam. Now, why do radiologists change to DD hip? Okay, so we can only see, we can only examine babies with hip until they are 6 months. Well, sorry, we can examine baby hips with ultrasound until they are 6 months. When they are over 6 months, towards 9 months or 1 year, then we can't do ultrasound because we just can't see through the bone. Because when the ossification in the hip is the first ossification center in the whole body, which ossifies. So when it ossifies, we can't use ultrasound. And that's why we change from ultrasound to X-ray. So if you're referring for DDH and it's above 1 year or around 1 year, X-ray, we can't do ultrasound. If it is in the first 6 months, by a push 9 months, we can do still ultrasound. Is this, do you have any questions, Mariam? Because it's a very important question. Kirsty is asking, ultrasound scan hands and feet or X-ray if suspected rheumatoid arthritis? Very good question. I would go for an ultrasound scan to look for synovitis and thickening, but you still need the X-ray to look for erosion. Although ultrasound can show the erosion beautifully, I think the pickup rate by radiologists, sonographers is very different. So you may miss an erosion if done by someone who doesn't do MSK on a regular basis. So I would say start with ultrasound definitely, but if you have really high suspicion, then do X-rays because it's only single view catch ball, and then we can get everything sorted. Graph type 1. Yeah, what's graph type 1? What's the question about it, Mariam? Okay, answer here from Mariam. We don't know what's graph 1. Ultrasound is a good standard according to God. Yeah, exactly. So we said ultrasound start first, but some may miss erosions. Yeah, that's what I'm saying. The research for methodology shows synovitis area ultrasound that would not find next day. Yeah, that's absolutely true. But you know, everyone is different, and the disease progression is different between each patient. Yeah, the recommendation ultrasound, we all agree on this. But as I say, it's good to have a baseline of X-ray. I think it's a low dose. It gives you the right information that you need. It looks for erosion, which is part of the disease process. Best imaging for possible osteomyelitis. MRI with contrast is the best option. Some would do it without contrast, but I think MRI is the best. X-ray would be too late to look for osteomyelitis, but it will be required just to give us a baseline about the disease and whether there's any destruction. We've got 1 minute, so I don't know if we'll be able to go through all this. X-ray osteomyelitis, I always have looked at. Okay, so Mariam is saying graph one, they need to understand what's graph one. It is a whole lecture, so we can go through it if you all want it. So please let the organizer know, and then we could do a small presentation about types of graph one and share some images and how we decide it. Katja asking a very interesting question. Am I right to believe that we don't have direct access to you? No, of course. I think you may. Yeah, I don't think you're right on this. To be honest, sorry. No, you have direct access to certain exams, and you can request CT scans. And I think this has been established for many years. We want to enable you to choose the right test. At the same time, engaging in this conversation so that you kind of fine tune your practice so that you ask for the right test and not causing unnecessary ionizing radiation and contrast nephropathy for no reason. There was a recent court case where the GP was criticized, the consultant was criticized for asking for a CT scan, and maybe it's something we could share it as well with you so that we can all learn from our mistakes. And the GP was seen on the wrong, the consultant was internal medicine consultant seen on the wrong, and I think it opened our eyes on how things are done. So no, you can request, so sorry, it's a long answer to your question. Yeah, you can request CT scan. Right, we are now 2 o'clock, and I think we've answered most of the questions. So unless there's any burning question or something that we've missed, then I would really like to thank you all for being generous with your time and attending today. I hope it was all helpful and useful to you. Please, if it was useful, don't forget to leave a feedback. I've left my name there so you don't kind of lose the spelling. It's El Sayad and it's Mohammed, my first name. And then write a comment. It takes only a few minutes, so please be generous with extra 2 minutes after this meeting to write your feedback.